Hyperkalemia is not just a lab abnormality. It is a disorder of cardiac membrane excitability which can rapidly become fatal. Potassium plays a critical role in maintaining the resting membrane potential of cardiac myocytes. Normally, the resting membrane potential is maintained by the potassium gradient between the intracellular and extracellular spaces. When serum potassium rises, this gradient decreases, making the resting membrane potential less negative. Initially, cells become more excitable, but as hyperkalemia worsens, sodium channel inactivation occurs, myocardial conduction slows, and the risk of malignant arrhythmias increases. The ECG changes of hyperkalemia reflects this progressive membrane instability. Early findings include tall, narrow, peaked T waves due to rapid repolarization. As potassium rises further, PR prolongation and flattening of P wave occur, followed by a widening of QRS complexes. In severe cases, the QRS merges with the T wave, forming a sine wave pattern, which can deteriorate into ventricular fibrillation or asystole. Importantly, ECG changes do not always correlate perfectly with serum potassium levels. Dangerously, arrhythmias may occur even without classical findings. The diagnosis is based on serum potassium levels, but pseudohyperkalemia must always be excluded, especially in cases of hemolysis during blood sampling. Common causes include renal failure, medications such as ACE inhibitors, ARBs, potassium-sparing diuretics, and beta blockers, metabolic acidosis, massive tissue breakdown, and hypoaldosteronism. In critically ill patients, impaired renal excretion combined with acidosis is a frequent mechanism. Management follows three essential principles: stabilize the myocardium, shift the potassium back into the cells, and remove potassium from the body. IV calcium, either calcium gluconate or calcium chloride, is given first to stabilize cardiac membranes. It does not lower potassium but reduces arrhythmia risk within minutes. Next, insulin with dextrose drives potassium into the cells by stimulating sodium potassium ATPase activity. Beta-2 agonist can also promote intracellular potassium shift, and sodium bicarb may help in acidotic patients. Finally, definitive removal requires renal excretion via diuretics. Potassium binders in selected cases, or urgent hemodynamic if severe or refractory hyperkalemia. Hyperkalemia is a time-sensitive emergency. The priority is not just lowering the number of lab, but preventing sudden cardiac death by understanding the underlying electrophysiology and acting systematically.